people try to corrupt it, to look bad. But being the good champions and messengers of the message on the ground, I want you to not to corrupt it. Just talk it the way it's supposed to be talked about. Are we together? Ukisema those things like twisting it, it sounds not good. I want to tell you something. We can politicize so many things. Lakini mambo ya afya, tuhakikishe our people first are done what? Register. That's how. Then you can make noise from inside in case of any challenges. So allow me to do presentation. You can scroll. Yes. Why shift to social health insurance? I want to take you back just a little bit. Social health insurance. Before this, there were 4 bills that were passed by Parliament. One of them was Primary Healthcare Act 2023. The next one was Facility Improvement Financing Act 2023. The third one was Digital Health Act 2023. And the last one, Social Health Insurance Act 2023. Why the shift? You remember, you see it's not just a Kenyan agenda. It's one of the SDG goals, and I hope you know that. And for a long time, starting from the NAC government, Vision 2030, there's been attempts to implement UHC. When we moved to the Jubilee government, again, several attempts to implement UHC. That is Universal Health for All. But it didn't kick up. Why? There was lack of proper policies and legislations. Certain things have to be legislated to happen because us, probably from this part of the world, we are not driven without any kind of a push. So the government felt it necessary that we must have certain legislations. That is why I've talked about 4 legislations. Primary Healthcare Act, Facility Improvement Financing Act, Digital Health Act, and Social Insurance Act. But for now, we are going to talk about SHA Act. It was meant to bring universal health for all. Previously under NHIF, of course, we were covered, but not everyone was on it. We think about, considering our population of about 50 million, probably 20% of the population was covered. We had principal members of about 8 million, overall, I mean about 13 million. So not everyone was on board. So SHA is supposed to bring everyone on board. Secondly, NHIF was mostly focusing on curative. When you get sick, you go, you get treated. But that is not a way to be done. We need to prevent certain things from happening. And that is why the shift is to focus on primary health care and preventive interventions. And that's why we have almost 107,000 community promoters spread all over the country, walking around households, taking vital signs, checking on your health. I hope that's happening. And finally, a bit emotive, but we understand, equity in contributions. Under NHIF, the minimum contribution was 500. The maximum, 1,700. Actually, when you tell somebody I'm paying 1,700, he will tell you, no, you are running 100,000 and above, those days. Because if you are getting 100,000 and above salary, you're supposed to have been deducted 1,700. But the minimum amount was 500. Take this case. Somebody earning 30,000, paying 500. Somebody earning 1 million, paying 1,700. Who's paying more? The person paying 500. Because if you consider the percentage of salary of somebody earning 30,000, paying 500, and the percentage of somebody earning 1 million, paying 1,700, then this person at the lower part of the income pyramid is paying more. So that is the essence of social health insurance. We need to ensure equity. Next slide. Yes. Now, let's get this very correctly, because this is where there's a lot of misinformation and disinformation. the Social Health Insurance Act 2023 established Social Health Authority, which is, in short, we call it SHA. Social Health Authority, SHA. Under SHA, we have three funds. The first fund is Primary Health Care Fund. The next fund is Social Health Insurance Fund. And lastly, we have Emergency, Chronic, and Critical Illnesses Fund. Now let me just explain why. Primary Health Care Fund is supposed to cater for level 2 and 3 facilities. In the healthcare system, we have a referral system. It starts from community-based healthcare where we have CPs level 1. Then we go to level 2, this is dispensaries and all that. Then we go to level 3, 4, 5, and 6. 6 is the last. So a place like Coast General is level 5. KNH, MTRH, Moi referral, those are level 6. So primary health care fund is supposed to cater level 2 and 3, those health centers dispensaries. Now, when you hear the government is saying that you go to level 2 and 3, you don't pay. It is publicly funded. It is funded just the way we allocate money for roads, water, through the Exchequer, National Treasury. Then the money is taken to Parliament, appropriated, and disbursed to level 2 and 3. So far, a few weeks ago, some money was already sent to level 2 and 3. I hope I'm clear. So what I'm saying, Primary Health Care Fund is publicly funded. The money that is allocated from Exchequer to Parliament, debated and appropriated. Publicly funded. So when you register under Social Health Authority, even before you pay any contribution, so long as you have registered, you get treated level 2 and 3 without that contribution. So long as you have registered, get it right. I say that because we have relatives in the village. They go and they are not registered, they will tell you, oh, send me 500 or 200, I cannot get treated. But you see, if they are registered, just registering only, they go to level 2 and 3 and get treated without paying. So get that far. Correct. Now, Social Health Insurance Fund, this is a contributory scheme. This is where the 2.75% that was deducted from your salary goes there. The 2.7% that the non-salary informal sector are paying from their gross income after mean testing is going there, cheap. In short, we call it cheap. So it operates more like the way we have in NHF, where your money was going. So that is a control scheme. Lastly, the Emergency, Chronic, and Critical Illness Fund. This is also publicly funded, just like the Primary Health Care Fund. The money that is from the Exchequer to Parliament and all that allocated. Now, why this Emergency, Chronic, and Critical Illness Fund? It has been introduced because when you exhaust your limit under SHIP, when you exhaust your limit under Social Insurance Fund, I give you an example of somebody with cancer, somebody going through dialysis. They are left to exhaust their limits. This fund will kick in so that we avoid the cases whereby we do the Arambe and somebody is selling property to pay for that. Hello? Can you hear me? Yes. So, I was told is this okay? I think the mic was a problem. What I'm saying, for emergency, chronic and critical illness fund, the government has set it so that when you exhaust your limit under shift, it kicks in. It is publicly funded, fully funded by the government, just the way Primary Health Care Fund is funded. It also takes care of emergency evacuation, ambulance and all that is there. But also note that In terms of emergencies, sometimes somebody is not registered under SHA yet, but accident. Under the Constitution, there's right to life. You cannot be denied care because you are not registered. In case somebody is critically injured, there's an emergency situation, you should be sorted out, other things will follow. So take note of that. Next slide. Now, many questions people are asking, which I've answered partly. What is social health authority set to deliver that NHIF did not deliver? About UHC. Not everyone was onboarded under NHIF. Under SHA, the regulations, it is mandatory for you to register. There's no option of not registering. It's mandatory. I hope that issue was being contested in the High Court, but still it's not been resolved because some people are thinking it's infringing on our rights. But you see, sometimes if you want to deal with bad manners, you have to legislate, make a law. When people refuse to do something, then you have to make a law for them to do it. But if, again, we were registering without being told to register or being reminded, there's no need for that kind of mandatory clause. So we hope that so far as yesterday, we have about 15.5 million so far registered. We hope that in a few weeks' time, we'll have the 50 million plus Kenyans onboarded. Second, in a few months' time, we are going to have a centralized digital platform for SHA. The essence of this platform is to ensure that we have a fully comprehensive electronic platform whereby the patient records. For instance, if you go to any facility, they can be able to look at it and know your medical history, whatever the test and all that. So that when you travel, maybe go to Kisumu or another county, you don't have to carry a lot of paperwork. The doctors there can always log in and see your medical details, and this will help you be treated effectively and efficiently. So that is another issue, why it's a shift. The other issue I've talked about is primary healthcare networks, which were never taken care of under NHIF. We have the level 2s and 3 covered well, and I've told you that so long as you have registered, you just access care free without even before you contribute. The other aspect is about financial protection. I've explained to you that when you exhaust the shift limits, the emergency, chronic, and critical illnesses fund will kick in. Previously, that was not provided for. After you exhaust under NHIF, you have to dig in your pockets. And finally, the issues of CHPs have really been legislated, and they are part, critical component of Social Health Authority. Actually, they are doing a lot of registrations on the ground. They drive to register members on the ground. Next. Next slide, please. Yeah, next slide, next slide. Now, just scroll again, next slide. I take you to the benefits. Yes. These are the questions that you've been asking. What is there? What are the benefits? Just a glimpse of what is there. But what I'll do, the Cabinet Secretary of Health gazetted these benefits and tariffs with various costs. It's something that you can access online. There's a gazette notice by the CS Health on all the interventions and the benefits and various costs that correspond to them. But just a glimpse, what is it that is covered under Social Health Authority? It covers medical outpatient services. It covers medical inpatient and critical care services. It covers renal care services. It covers medical imaging services. It covers rehabilitative services, screening for common diseases, overseas treatment, maternal and child health services, surgical services, oncology services, dental health services, assistive devices, optical services, end-of-life services, accident emergency services, specialized pharmacy benefits, specialized essential diagnostic services, mental wellness services. Allow me to highlight a few areas that may be of interest that you can also inform the public about. Previously under NHIF, issues of dental were not available. It was only available if you are enhanced, if you have what is called enhanced scheme, like civil servants and police service. They could access dental, they could access optical, even issues of assisted devices. But under SHA, everyone, so long as you are registered under SHA and contributing, you will be able to access dental services, you will be able to access optical services, and of course, another service which has also been introduced, which was not there also, is end-of-life services. If you die, God forbid, or a relative die under SHA, you'll be taken care of in terms of the mortuary charges per day. Are we together? You know, there are certain communities or people who cannot even raise the money for the mortuary. So we fundraise for that little amount, whatever it is. So that is well covered. Now, another issue that I want also you to know, renal services. Previously under NHIF, we were paying for dialysis, but we are paying 9,600 per session. Under SHA, it has been enhanced to 10,650. And again, for dialysis patients, we never, under NHIF, we never used to use what is called pre-evaluation. Care for pre-evaluation. Before you get the transplant, there's something called pre-evaluation of the patients. That is now covered. It's now covered. And again, the amount that was covered for the transplant was about 450,000. That has been increased to 700,000. Again, post-transplant care. After transplant, you need medication, you need that care. That is also covered under SHA. So get it correct. Again, oncology services. Oncology for cancer care, it was a bit limiting. For now, every household per person is allocated 400,000. You are allocated 400,000 shillings. If you exhaust that, then the emergency, chronic, and critical illness fund will kick in. Are we together? You'll ask me questions and I'll explain. So there are a lot of value addition currently under SHA that compared to previous NHIF were not there. Can we go to the next slide? Next slide. I think I've talked about that. I don't want to go about that. Just proceed. Just go. I will leave this slide for you also to have it, so that I don't want to go to the finer details. You can go through it also to understand much better than disseminate the correct information. Now, there's this question about Linda Mama, that Linda Mama was scrapped. No, it is not scrapped. Previously under Linda Mama, in fact, the mothers who were paying to NHIF were not getting as much benefits as compared to the Mama program. But now, so long as you are under SHA, whether you are previous under the Mama or you are paying contributor, the benefits are equal. And again, they have been enhanced. Previously under NHIF, the visits, they were limited to 4 visits. Currently, they can do 6 visits. And this covers both prenatal care and postnatal care. Previously, the normal delivery, it was only 5,000. Now it is 10,000. For the CS, previous it was 15, but under SHA it is 30,000. So the message is, Linda Mama is still there. It's only that it's not being called Linda Mama, but all mothers on a Lindwa, they have been taken care of. All, whether you've been paid. The name is packaged. It's not being given a brand name. Just like, let's get it clearly. It's not been given a brand name that we have this kind of a brand name. It is falling under maternal and child health care services package. Are we together? It is clean amount. It's just falling under maternal and child care services package. Let's get that one right. Next slide. People also ask questions about Eduafia. Eduafia was purely for public secondary students. Public. I know some of us, we are students in private schools. So they were not even benefiting from Eduafia. But currently under SHA, all students from primary up to university, so long as you are in the age bracket of 21, unless if you are in the university, you can produce up to the age of 24, you produce a letter to confirm that you are still on course, then you are still considered. So long as they are registered as dependents, they will access the same packages under SHA, whether they are in public schools, whether they are in private schools, or whether they are international schools. Are we together? So it has brought some kind of equity. Previously, it is only public secondary school students that were benefiting, and of course, it was a bit discriminatory because all of us are taxpayers. Next. Now, where can you access services? Where can you access services? All public health facilities, those ones under the county governments, even the ones under national government, are contracted under Social Health Authority. All. About 6,000 plus. Secondly, almost all private health facilities, for instance, if I talk about Coast Region, I know all private facilities are under Social Health Authority contracted. All. The same applies to faith-based, those ones owned by the churches. They are also contracted by Social Health Authority. So you can get care wherever you are, in any part of the country, without any hitch. Next. Yes, I think this is a question that you'll ask, a bit emotive. For the people who are working, we are deducted 2.75% of your salary, gross salary, and I think you felt it last month, and again it will continue. The question is, people asking, I'm working, and my wife is working, we all get deducted. As journalists, you are well informed, and you know there is a law statutory deduction. So unless that law is revisited and revised, still will be contributing, and you're always contributing, both spouses. Now, the minimum contribution is supposed to be 300. For those people who are not working, can you just scroll? The people who are not working, just scroll again. For those who are not working, they are supposed to contribute 2.75% of their annual income. And there's a tool called mean testing tool, where you go and answer the questions, then it will give you the amount of money that you're supposed to pay in terms of the premium, either annually, to give you both annual expected amount to pay and monthly contribution. So far, the tool is working okay, because if you look at the outlay in terms of the contributions from this new testing tool, the majority are falling between 450 shillings to 1,000, almost 60-70%. And that reflects the nature of our income distribution, which is at least majority are not okay in terms of the bottom heavy, but the top, they are 50 by the top of the pyramid. The other question that as you engage the public, that I want to throw a question, most of them when they do the mean testing, they go to the cyber. Once they go to the cyber guys they need money, and it depends on how many they have done for. So they just take for you the parameters, the questions. Then you end up being told, oh, you have to pay 80,000. If you look at that, you are not able to pay. So I prefer that either if they can go to the Luma centers if they cannot do the mean testing, or they look for the CPs who will guide them on how to do the mean testing, so that you can get the correct amount. Now, in cases whereby you do a mean testing and the monthly contribution is you are not able to pay, then you'll fall in the category of the people that the government should take care of you in terms of paying for you. So get that clear. Next slide. What about registrations? Very important. I hope all of you, I know you are maybe employed, you are previously under NHIF, and you got a text message that your data was migrated from NHIF to SHA. Even if you get that message, please, it's important to validate your data. Still, you can go through the process, confirm everything is okay, ensure all your details and dependents are well captured. But for now, if you want to register, we have the USSD, star 147 hash. You dial star 147 hash, it will prompt you to whether you are a citizen or a foreigner. It will prompt other aspects, then you just continue like that and proceed. Being a journalist, I think you know how to use the USSD. And this star 147 hash has a meaning. 47 counties, one nation. So it's very easy to remember. 47 counties and one stand for one nation. Now, the CHPs, the community promoters, they have the gadgets they were given. These gadgets were installed with some applications. So they can help you to register if you are not able to register, even though they've been testing. Again, if you visit the Luma centers, I tell you we have counters there for SHA. You can do the registration. If you visit the former NHF offices, now SHA offices, you can do the registrations. In almost all healthcare facilities, be it private, public, and faith-based, if you engage them, they have set a desk to help people go through. Because we find cases whereby somebody has gone to a health center or dispensary and he has not registered. But the moment you register, you can access care. You don't have to wait for the 60 days the way it used to be before. But for under SHA, immediately you register, you get access to treatment, you get access to services immediately. You dial that star 147 hash, and your data is captured well and reflected in the system. You can access your services immediately without waiting, immediately. Finally, there has been a proposal to even identify, as we go forward, identify certain outlets that can help us to drive this. That has not been done. It's in process. But as I speak, we have the CHPs, we have partnered with national government, that is regional commissioners' offices, county commissioner offices, we have partnered with the chiefs and chiefs. They are working from household to household to ensure that our people are registered and are well captured. Next. So I've talked about those networks, the Duma centers and all that. I've also talked about the platforms, the USSD. You can also do the website, the www.sha.go.ke. It will take you to our Yangu platform, which you can actually do the mean testing and even update your dependents. So as I've said, you also have a call center in Nairobi. The toll-free line is there, which you can always call in case of anything, then you can sort it out. Next, I think that should be the last. That's just information. Yes. So, yeah. So I will stop there, but I suggest that you circulate this presentation, and again, I'll also send you the gazetted tariffs, which has details of the amounts of money, which are attached to all the interventions. Almost all surgical procedures are covered. Can you just scroll if there's something I've left? No, I don't think there's something I've left. Now, there are certain exclusions. For instance, for cosmetic surgeries, it's not covered. If you want to look beautiful, or you want to be, I want to be lighter, to look like I'm Zongo, it's not covered. Again, for ladies who wants to have the nyash, the buttocks, see, it is happening. Or they want to trim their tummy, flat tummy and a big nyash. That is not covered. For men who are disadvantaged and you want to improve your gadgets, that's not covered. Yeah, it's happening. Yeah. You want to impress. I think the topic here was interesting. It's only that we didn't talk about such things, eh? Yes. You want to impress, so that's not covered. So, herbal medicine and all that, seeing a herbalist and all those kind of things are not covered. So, there are certain exclusions which applies to most insurance covers as well. So, with that, I'll stop there and I will take your questions. Thank you.
I think there are no questions. So let's start from here. Alafu, you take short time for everyone to ask.
My name is Eric. Nafanya kazi pale Nakuru na niko na maswali mengi sana. Mimi kama kijana na imani kwamba nazungumza kwa niaba ya wazo wa vijana wengi. Na having that in mind, unakuta kwamba vijana wengi, kwa sababu sio wengi huwa wanakwenda hospitalini kujitibu. Utakuta kwamba masuala ambayo wanaweka kipaumbele ni masuala mengi, labda tumbo, kupata hela na mfano kama haya. Lakini ikifika masuala ya afya ni ngumu sana kwa wao kutilia maanani masuala kama haya. Na baadhi ya vitu ambavyo vinawachangia kiasi kwamba usifikiria masuala ya kujishirikisha kwa kujiunga na SHA ama SHIF ni kama haya. What is the assurance for me as a youth? Nikienda pale hospitalini kwamba SHIF sasa katika daftari ambayo naiona hapa ina cover level 2 and 3. Mimi naishi mjini Nakuru, sasa is a city, and I live in Rongai constituency, and the nearest hospital kwangu mimi as a youth ni Mercy Mission Hospital PGH level 5, and Mercy Mission Hospital is a level 4. Mimi kama kijana ambaye nimejiunga na SHIF, nina wale ambao wanategemezi, wale ambao tunaita beneficiaries ambao nimeweka hapo kando. Mzazi akigonjeka, mfano au mwena jino, nimpeleke hospitali, niambie kwamba hospitali ya level 2, 3 ambayo iko kwenye eneo bunge langu haiwezi ikakuwa cover na SHIF. Inabidi niende wapi? Mercy Mission level 4 ama 5. What is the assurance? Ukienda pale level 4 ama 5 wanakuambia we don't accept SHIF. Sindio? Level 5 and 4. And if they do, they shy off for kuambia kwamba we accept. Reason being, they are not assured that watapewa pesa zao za huduma ambao wamefanya. So what is your assurance that you guys mnaweza mkafanda hawa level 4 and 5 so that wapeane huduma for me to take my mother to the hospital atolewe jino na aweze kupona?
Thank you. Mimi kwanza naitwa Niko. Nashukuru mtoto wangu alitibiwa na SHA. Asante. At least ilianza kufanya. Lakini nina swali moja. Sijawahi sikia advert ya SHA.
Can you repeat that so that I can hear?
Sijawahi sikia advert ya SHA kwa community media station. Siku hata moja. Kwa nini hamtumii media za community to create awareness kwa SHA? Lakini tukiwa na mkutano wa community, mnakuja kutueleza masuala ya SHA. Question number 2, SHA ilianza kutumika Oktoba, lakini ilianza kutumika rasmi November. Between November and October, watu walikuwa wanatumia fedha zao. Kujifungua ilikuwa 10,000, CS ilikuwa 30,000. So my question is, kwa nini serikali ilichukua muda mrefu kabla kuelezea mwananchi kile ambacho kinaendelea kwenye masuala ya afya? Na swali ya mwisho, huyu kijana mwenzangu, swali ambalo alikuwa nataka kuuliza, kwa nini ukienda level 4 unarudishwa ukaanzie 2 na level 4 inaweza kuwa ndio iko karibu na wewe? So huyu alikuwa anauliza, akiwa mgonjwa akitumwa tena level 2, huo ugonjwa wake unaweza zidi aende 2 ndio arifaiwe 4. The last question, umesema kwamba haya masuala yanaanza level 2 na ukazungumzia end of life. Pia mtu akifa ataanzia level 2 ama atachagua mochari yenye anataka? Asante.
Allow me to answer. Excuse me.
Yes, you can answer the two.
Let me answer this one. that they are not crowded. Then we take another set of questions. Thank you for these wonderful questions. Very, very good questions. First, I said that when you start accessing care, you are expected to go to level 2 and 3. It doesn't mean that you cannot go to level 4 or 5. Why is it so? If you go to Coast General previously, if you go to KNH, by the way, I was head of risk and quality assurance at KNH, International Hospital, before I came to NHIF. You'll find people walking in at a level 6. A level 6 and 5 is a very serious facility dealing with very specialized complex issues. In fact, we used to make fun that some people will go to casualty at Kenyatta with malaria or some small ailment. The moment you go to there, you'll see even people who have got accident where the head is even missing. So you just recover from there. Now, those level 5 and 6 are not walk-in facilities. You're supposed to be referred. The Ministry of Health has a national referral strategy framework which guides us on how to get care. So that when you are coughing a small thing, start with the dispensary of level 3. Why? You see, when you go to those level 4 and 5s and you are seeing a consultant, even for coughing, you pay a lot of money. And by the end of it, you have done so many tests, and you are given maybe a Panadol and all, and you are paid even 10,000 out of that. So you even exhaust your limits. So this SHA model is trying to reconfigure our health-taking behavior so that we are streamlined in a way that we also save on the cost of care. But if you go to level 2 and 3 and they cannot handle you, you are referred to level 4 or 5 or 6. Are we together? You are not stopped from getting higher level care because you just go to level 2 and 3. They look at you and say, no, we cannot handle this case, write for your referral letter, and you go to the next level. Now, the other question, there's no advert in community media stations. Yes, and that's why I'm here. And I'm happy that you are engaging. And that is why somebody was asking me, why are we signing this register? I'm signing the register so that you can have your contacts. Are we together? These contacts I'm going to share with our media, the media team being coordinated from State House, and the media team, and the media team being connected. Please. Kidogo, are we together? We have a media team from SHA, we have a media team from MOH. It is multi-sectoral approach. Are we together? So I'm going to share this because already we have been engaging with the local radio stations and local TV stations. Personally, I've been invited to the More radio station. I've gone to Swahili Port. I've gone to JK FM. And again, that is your USAID. We have so many. I think USAID has invited some of the local stations. Next week on Tuesday, we are going to engage. So the purpose of this engagement is to find an entry point because you are at the core of passing the correct information to the grassroots. So we are going to engage. That is why I circulated that list so that you can have your contacts. And you are going to be used very well. The other issue, when we started on 1st of October, just like any change of approach, of course I have to admit there are certain challenges. So most people were not able to access because of data issues. Your system cannot be visible, your name. We apologize for that kind of an issue. But one thing we did for patients that were on chronic issues, chronic illnesses like cancer, dialysis, we ensured, there were few incidences on the media, in Nakuru and all that, but I would say 99% of those kind of patients with oncology and the dialysis, their care was not disrupted. Even our mothers that delivered, we ensured everything. There was a plan B for that. But in case you are affected by that, we apologize for that. It happens. No system is 100% perfect. So it is not that the government did not inform the public about the change. We launched it publicly, there was media, it was publicized, but again, people were also skeptical. So people may have missed to register, to transit, and that could have caused some hitch. For now, we realize that certain level 4s, there are certain areas whereby there's no level 2 and 3, you can only access level 4. So what has been done, level 4s have been included in the primary healthcare networks. So for now, you can go to that level 4 in your village. If there's no nearby, level 2 or 3. So get that fact correct. We send information to all providers to show commitment that they can be used as part of the level 2 and 3, like part of the PhD primary care networks. So currently, all those level 4s around you, you can walk in for outpatient care services. This is interesting. End of life. My friend, end of life you can die anywhere. It doesn't need a level 2 or 3. If you go to a level 2, I don't think they have even mortuary. Even level 3, I doubt. Most mortuary services are from level 4s and above. Is it true? Mostly. So when you die, how do you choose where to go when you die? No. When you die, you can be taken to any mortuary, whether it's a level 6, a level 5, both private, public, where the nearest. Are we together? So that should not be a problem. I can take the next round of questions, please. Thank you. Madam, I can take the next round.
All right, we keep our questions short and sweet. Time is bad. Na chakula inapoa.
Sitachukua hata dakika moja, itakuwa nusu. Thank you so much for explanation, lakini hata umenichanganya zaidi. Number one, sasa kuna SHA, taifa. Sijui ni nini tunazungumzia, utanisaidia. Number two, umetaja maneno mazuri sana, lakini I think you've got a good concept note, lakini you feel the mood of the journalist. Unatuchanganya zaidi, kwa sababu vitu ambavyo unasema na kitu ambacho unaripoti tofauti. Then nataka kuuliza, labda ningepata CEO angenijibu. Nashangaa majina haya mnayabadilisha. SHA, taifa, labda itakuwa jamhuri tukifika Disemba tarehe 12. Kwa wao hii change. Alafu la mwisho, I wanted to understand katika NHIF tulikuwa na labda mtu kama mimi najilipia haikati 2.7%, nalipa shilingi 500 penalty, najua ni 250. This one is not even clear how much. Saizi hata sijai lipa SHA haifanyi. In some regions that you're working, even those guys ambao walikuwa NHIF, they don't know SHA, taifa. Sasa tutaregister nini? What are we telling the community? Kwamba tunaregister nini? Na register taifa care hii, ni SHIF, ni huduma, what are we registering for?
Shukran, utanita salisi. Na number one, I didn't get your name.
My name?
Yes.
Douglas Odhiambo Awino.
Douglas Odhiambo.
You can search me online to know me better.
Okay, sir.
Because I heard some of you that they went to Europe for the first time. I studied in Europe.
Thanks for informing us about all that. Sina maswali mengi. I have reactions. Number one, let me just stand up. Number one, we have someone in this room mwenye amekuwa akitegemea NHIF for dialysis. As we speak, he has had to pay for 3 months. Number two, I have a brother battling blood cancer. NHIF ilikuwa inasimamia hospitali kila wakati akienda kufanyiwa nini chemotherapy. He has to be in hospital for at least 9 days. Kuanzia October ilimpata kwanza transition kama hospitalini. We had to changa urgently 34K to cater for the bed. Ukienda pale unaambiwa ya kwamba hatujaingia makubaliano and all that. I had to walk myself to NHIF Nairobi offices hakuna mtu alinipea information on how my brother is gonna get help. As we speak, or as I stand here, there's a woman I know amekuwa Mbagathi District Hospital for more than 3 weeks because she could not raise 9,000 shillings. Hiyo yenye unatuambia kwamba Mama Linda Mama inafanya. I don't know hiyo Linda Mama inaendewa to specific because we report from the community. Personally, I work in Mkuru kwa Ruben. My office is in Mkuru kwa Ruben. Watu wanakuja, we have a hospital, we have a health center there. Watu wanakuja, ni mtu wa kansa. Amejaribu, ameshindwa, amerudio level 2. When I see officers stand before us and command us to report what we can't see, what we can't hear. Remember to relate na watu kwa community. You are in the office. Have you taken your time kutembea kwa community? Have you walked to those hospitals? Have you taken yourself to Kenyatta National Hospital to go and see what is happening there? Wacha tuliachia hapo.
All right, so we can get to this side. Let me start.
Hello. Jambo. My name is Joseph, and I'm taking you back to a question that my brother over there had asked about media engagement. Sometimes this regime, I think it is either last year or early this year, cancelled all the contracts, social contracts with private media. Wakabakisha sasa kazi zote zinafanywa na KBC. I remember qualified to provide government services in media or through different media houses, and that was cancelled. So my question is, when the government now comes to us as community media to do their work for free, when mkataba wenye tulikuwa nao before, they cancelled it, how are we doing it? For free or on what context, when the same government was very clear that they are no longer watakuwa wanatumia mitambo yao ya KBC? I think it is a point that some of the things that I was told it is because of the government relationship with media and how they are going about everything that surrounds it. So it is something that you have to ask them if they can reconsider what used to be there before, because a number of media houses from national level to the community level could get jobs from the government. They stopped that, but here they are sending you to come, tell us to go and do that job that for free. It does not work like that. It is a two-way traffic. Yep.
Hey, 1, 2. Let me start here and then to you. To you. A second.
Mine is a quick one. The system where if I pay cash and then the money is refunded through the hospital, what happens with the transition? I'm asking because I paid some money for my dad's surgery. Then I started following up. When it was still NHIF, I was told the systems were improved and there was a struggle getting that file. Now that there is no longer NHIF, do I still have hopes?
Thank you. My question is on the 2.75% that you deducted from my payroll. You mentioned that it is a household, and the other day I just checked my payslip and realized that I was deducted 2.75. Is the government trying to assume that my wife is not employed if it is a household thing? And if it is the case, does it mean we have to do an equal contribution, the 2.75%? And what happens to people like where I come from, where somebody is allowed to marry up to 7 wives? What happens?
Right. So last to and him, then we can allow him.
Yeah, thank you very much. I have
two issues. Number one, when you are starting, you say that we should not politicize this activity.
Not this activity, your health, my health.
Yes. Thank you very much for that clarification. One, I understand that the MPs were being trained about this. And they're coming on the ground to talk about it. And as we are reporting, it becomes very difficult to demystify what the MPs have said, the politicians have said. So there's some double speak. And actually even to hear that your media unit is based in State House, it's also actually very...
I'm not saying it's based in State House. I'm saying coordination is multi-sectoral approach by the government. Please, don't misquote me.
I thought you said
Not
based in State House.
I'm saying coordination is a
Okay.
multi-sectoral approach.
Okay.
Yes.
Let me ask a question on the means testing tool, because I think there is a problem. Because if I go and say that I stay in Kireshwa, because that's where I was born, but now I'm not employed, does the means testing tool, will it capture me as someone who is wealthy because of where I stay? Or does it have some human intervention other than going to the office and this being captured?
Okay, I have a question on, I think there are two questions. One, why did the SHA exclude clinical officers and their facilities from providing services, and also on the nurses from providing imaging services? Doesn't that undermine their ability to provide quality care and limit patients' access to essential health services? Thank you.
Right, last one, then you respond.
Thank you. I'll ask, but it's something that has already been alluded to, but I think you'll just clarify further. We are working towards universal health coverage. Now, when you say, especially for us who live in urban areas, getting access to level 2 or 3 might be a challenge. So if it's only level 4 and 5 that are close to me, does it mean I'll have to travel for a long distance, probably to the village, for me to access services? Remember, we are trying to improve accessibility of services. That is the first one. So how are we improving UHC while at the same time we are blocking people from going to the facilities that are nearest to them? The second one is about acceptability and your independence, because you said I should not misquote you, or rather we should not misquote you, but you said you'll share our contacts with State House. So who is really, where is the independence?
I'll say with the media team. Just a minute. I'm saying with the media team, which is coordinated with all the relevant departments. So I just mentioned we have a team that also coordinates from State House, from MOH and all that.
That's why I said I'm
So,
just quoting. So
yes,
you clarify this.
Yes, so don't
No, I'm just wanting to,
please.
we want to get the independence of the entity so that we are sure of accountability and management of funds in terms of that.
No problem.
All right, you can take less than 5 minutes to respond.
Yes, so I want to clarify first about SHA and SHIF. Social Health Authority is the institution body corporate that can be sued, and you can see whatever it is, just like any entity, your employer. SHIF is a fund under SHA. I think some of us were not attentive. Under Social Health Authority, there are 3 funds. Primary Health Care Fund, SHIF, Social Health Insurance Fund, and finally, Emergency, Chronic, and Critical Illness Fund, 3 funds. So SHIF is just one of the funds under Social Health Authority, SHA. And of course, it is a contributory scheme where you have to access based on your contribution. So get that one clearly. The issue of Taifa Care. I know you are referring to the President's pronouncement during the State of the Nation address. Taifa Care, under the law, we have Social Health Authority. Taifa Care is just like a brand name to to ensure, you know, when you go to Mashinani, those lands, if you start talking jargons of SHA, they may not understand. But now when you talk about Taifa Care, it is simplified, well understood. It sounds more inclusive. Just like under NHIF, we had Super Cover. And again, we had those programs like Nina Mama Eduafia. They were products given a brand name. So the old brand name of this initiative, for you see, the government has decided to brand it Taifa Care. Let us not misread a lot from that. It's just but a name to look more inclusive. Are we together? Madam, you talked about some tools, study cases. I really feel touched about the issue of dialysis, the issue of the patient cancer. I will request you kindly, after this, I'd love to get your contact. It is not within the region coast, but those are Kenyans that must get whatever they deserve, especially matters cancer and dialysis. I'll get your contact, you share those details, I will follow up. Are we together? Including that issue of the mother, please. So that in your forum, you give them feedback that things are okay. So, me, I don't make promises, I meet my promises. So we follow up with you. Yes, I say that because I understand how to live with chronic issues. Yes, about life and death. So that's a no-joke issue. Social contract. There are certain questions which I may not want to answer. In the hierarchy of government, I'm not a big man. So when you want to ask me about why the government has not engaged those your media on contracts, for now, I beg not to talk about that because first is not my line of duty. That's outside. But for this engagement, I want to promise you. That is why I'm very open with you to tell you about our coordination in terms of media engagement. I'm not hiding anything. Sasa? Yes, so that you don't say that last time I didn't tell us how we are going to engage. So for this initiative, for us to succeed, we must take strategy and you will be onboarded. In terms of any compensation, in case of their raise, of course you cannot work for free. You will be told how much you can be compensated. Are we together? Yes, please. For somebody who said that you paid cash previous under NHIF and not reimbursement yet, SHA inherited all the assets and liabilities of NHIF. If you have those receipts of what you paid and you're not supposed to pay, check them to the nearest branch. They will follow up because we don't reimburse directly. If that facility was paid for that surgery or for that procedure, we'll tell them reimburse because you cannot pay and you pay. Are we together? So follow up with the nearest branch. In case you, which is the nearest branch? Of NHI or from NHI? Huh? Kisumu? Yes, I'll refer you to the regional manager, Western, so you can get in touch with me. Then we work on it. Somebody also raised issues of involving the MPs. My friends, a government agenda, we cannot isolate the political environment from it. Let's be honest. They are part and parcel of this. And by the way, MPs are Kenyans, they are human beings. It's only they have been elected to represent us. So any project, even you, when you want to buy in for certain programs, you have to work with the political people, political sector. You have to work with the MCAs, with the MPs. And the messaging is what is important. The messaging is, one, let our people register. If there are issues with services, challenges, we'll deal with it. Mean testing tool. that tool as parameters. So based on the questions you are answering, you are the one to answer the questions. Especially after, if you are salaried, if you are employed, you don't have to do mean testing. It will only take you to mean testing for non-salaried. Are we together? Because it will determine what you're supposed to pay monthly or yearly. Answer those questions correctly. Kama unakaa Nyali, usidanganye, sema nakaa Nyali. Kama unakaa Bombululu, whatever you have, just say it. Because for some, if you are doing business, filing returns, and you cheat, probably these systems are integrated. You may look at the other end of your returns and say, oh, this guy did not give us the right information. So let's try to be truthful in terms of that. In terms of the 2.75% contribution, for the salary, I say your wife is deducted, the husband is also deducted because it's a statutory issue, law. For the non-salaried, it is household income. So whoever pays is the principal, the owner of the house. If the lady is the household lead, or it is the man who leads that household. So it is the person who is the principal that is paying after doing the meat testing. Now, it doesn't limit to the number of wives. It is, the household is in Africa, it is a man, one wife or 10 wives, So it doesn't limit you. But I don't think in Africa there is a household with the one wife and 20 husbands, So I don't know. So it doesn't limit you. So somebody is talking about why exclude clinical officers. I don't want to comment on that. There's a conversation going on because previously under NHIF, they were part and parcel of that in terms of their facilities, they are running them. The Clinical Officers Council, they're engaging, and the regulation is very clear. So that one is something that is ongoing to be resolved. For issues of nurses being involved in certain aspects of imaging or maybe approvals and all that, we have clinical guidelines that guides who should do what. The nurses, the clinical officers, doctors have their rights and privileges based on their profession and what they should do. So if there's something that they are supposed to do, they'll do it based on their profession, their rights and privileges. If there's something they're not supposed to do, they'll not do it. So that one I leave it to the professional bodies. If you have those questions, they can clarify if there's a challenge. But so far, I've not had anything to do with the nurses. In terms of access to facilities, I said that in an area where there is no level 2, 3, you can access a level 4, and they have been put in the PhD network, lecture networks. I don't think you can go to an area where you lack level 2, 3, and 4 now. You have to get it. So as much as it's a concern, but let's be practical. Almost all facilities are onboarded. You can access your care level 2, 3, and 4 as a patient without referral. So which means that it's only level 5 and above that you have to be referred. So in terms of accessibility, I may not have a measure, but so far, people are getting services if they are registered. Tafadhali, tafadhali, if you have a friend, tell a friend to tell a friend. If a relative, tell them to register, not to wait. Waingie kwa hospitali ndio wakuwe na shida. Tafadhali. Thank you.
All right, tumpatie makofi. I can feel the energy. Sinajua mimi ni psychologist, I can feel your energy. But I think what we can do, sir, together with your team, we are still here. We are having the evening dinner. If you can just have a desk, ama hata kama ni hapa ndani, for people to come and ask questions and for you to respond effectively. So kama mlikuwa mnapanga kuenda, tunaomba mbaki, and whoever has a question, please do it on a one-on-one. See, iko sawa? Ama bado?
Madam, let me clarify something which I forgot. Somebody asked about the dependence of allowed to do our work. Every institution, based on the law that is established, we work within the parameters of that law, within the mandate as instituted. So SHA is working independently, but doesn't mean that we don't collaborate, we don't partner. We cannot work in isolation. We work with all government entities, be it Ministry of Health, be it Interior, be it Agriculture, be it Labor and Social Protection that is with the vulnerable. We also work with non-state actors like you. So we work in partnership with all. So let's that very clear. Thank you.
All right, makofi kwake. Great. I believe we've been able to get 1 or 2, 3 things that we can carry with us. And so this is the last part of our session for today. And I must say that you guys have been an amazing audience. Simjipigia makofi. Hata kama mmetoka, hata kama mko na njaa jameni, msijinyime makofi. And it's been an honor being your MC for the last 2 days. I hope I have done you justice. Ndio mdosi aniite next time. Sindio? Right? Great. So I will invite the chairman, LGJK, to come and invite the person who will be closing the conference. But again, it's not yet over. In as much as you have done me justice these 2 days, you still have me in the evening. So I can't wait. Sasa ingine itakuwa less formal. Sawa? Now ingine now you'll see the Gen Z in me. This was corporate. So tutapatana in the evening. So join me in welcoming Mr. Dennis Beru to invite the person who's speaking next. Wapi makofi yake? But before we do that, I think we should stand. Let's stand up. Naomba tusimame. So now, so this is what I want you to do. I want you to pluck a piece of paper. Mimi siwaambii ile ya chairman, ile ya fanya hivi, fanya hivi. Hata mimi nilitengeneza vitu zingine ajabu. So I want you to pluck a piece of paper. Nimeona kuna watu hata hawajakuwa wakiandika notes ndio wanafungua kitabu sahihi. Very nice. So pick your pen. So I want you to write one word that defines unlocking media potential. You see our theme? Unlocking community media potential. So I want you to write one word that describes unlocking the potential of community media. So you write one word, you give it to the next person, until it gets back to you. Unaandika, pass paper to the next person, anaandika kitu ingine. So you write different things in different papers. Are we together? You write different things in different papers, but one word. And you only rotate it to the people that you're seated with. Yes, mupeane. So uandike until ile pepo ulikuwa umeandika imekurudia. And make sure it has been written by kila mtu kwa hiyo table. One word that defines unlocking community media potential. Aya, 30 seconds to go. Alafu ilikuwa individual work, si group work. So munataka kuibia. So what I will do is, I will go to 3 tables and just pick someone randomly to read what has been written in their paper. Na karatasi yako ikikurudia, just keep it. Keep it for yourself. Great. So I will randomly come to you. Aya, if we are together, clap twice. If you can hear my voice, clap once. Ni kama watu huko wanisikii. Watu ambao wako hii side, if you can hear me, clap once. Aya, table hii hapa, if you can hear me, clap once. If you can hear me, clap once. If you can hear me, clap once. Sawa. So now, I want, nataka unisome what has been written in your paper.
Okay, what has been written is partnership and participation.
Partnership and participation. Group work is over, sitaki mamaring.
Coordination, insightful, independence, and partnership.
Coordination,
partnership, networking, teamwork.
partnership, networking, teamwork. I hope you're noting what you're getting.
Target audience, integrity, empowerment.
Target audience, integrity, empowerment.
Partnership, accountability, availability.
Partnership, empowerment, accountability, availability.
Factual, collaboration, partnership.
Partnership is really coming out.
Impressive, critical, impressive and critical.
Okay.
Strategy, referrals.
Strategy, referrals. Okay.
Relatability, networking, and collaborating.
Relatability, networking, and collaborating. Kuna meza ambayo nimewacha? Wasiseme oh, huyu MC alikuwa biased. And oh, hakuna. So now Susie says sit down. Stand up. Sit. Stand. Hey, it feels nice to make people take orders. Okay, so now let's give a round of applause to Mr. Davis.
Thank you so much, Madam Susie, for being a good MC. Of course, this is, or it has been a great moment for the two-day conference, highlighting on different issues that we, community, media, journalists, and practitioners report on a daily basis. So I do not want to take much time on this because we have a few minutes or rather hours during the gala at 6 p.m. So guys, kitu ya kwanza ni kuwashukuru nyote na kwanza kabisa the presence of the regional manager for SHA for coming to clarify on a few things, and I think I will still want to challenge him. We need to have a conversation strictly with community media journalists, have a discussion on how we can have this conversation
trickle down to common mwananchi. And then of course, Bwana Awino, I've been in conversation with the head of corporation at SHA, that is Daktari Nyakiba. Of course, next year we are going to have a media campaign on community media, highlighting or rather sharing more information on the SHA conversation. So I know guys, we shall reach out to you soon because I started the conversation back in March, and the conversation will start probably next year. So at this time, I really want to invite, we shared or we sent an invitation to the governor of Nairobi because we work closely to attend our conference. Unfortunately, he was not able to be here. Lakini, we have Chief Officer for Public Participation and Customer Care Service. Tafadhali naomba tusimame tuweze kumkaribisha kwa makofi Madam Zipora Njeri Mwangi. Wapi makofi tafadhali?
Let's have our seats. So thank you very much, the chair, Kakaberu. I can already tell that our energies are low, so I won't keep you for long. I'll be very brief. I am Zipora Mwangi, Nairobi County Chief Officer for Public Participation, Citizen Engagement and Customer Service. We are the feel and the look for Nairobi County. Our vision at Nairobi County is we want to have a city of order, hope, dignity, and opportunity for all. I want to start by recognizing the various stakeholders that has enabled us to be here. That is the Habitat for Human Kenya, KenGen, MSF, Social Health Authority, Forum Civic, WhatsApp, I don't know what that means, WASH, SATO, and among others. Ladies and gentlemen, you will allow me to read through my speech, but before then, I want to pass the greetings of my boss, His Excellency Governor Sakaja. I am here with his blessings, and he knows that we are already here having this conference. And AGJK is not new to him. We have worked with him. I know your media stations have been publicizing our stories, especially Sakaja at 2. I just want to see whether we all know the programs that we are running at Nairobi County. How many of us know Dishina County? By a show of hands. Dishina County. So far, we've already fed, we've given out 30 million meals for the last 2 years into to all our primary public schools in Nairobi. We are also doing markets. Are we aware that we are doing markets at Nairobi? Yes. We have a project that is, we are partnering with the national government where we are supposed to build 20 markets, but at county level we are already doing, and we've started with Jujo. We have a current market, and we also have a Mutini market that is almost coming to an end. I would also like to know whether we all know the opportunities that His Excellency has created for the young people in terms of allowing the young people to, the ones that are coming up with content creation, to be able to access facilities within the CBD during weekends without a pay. Are we all aware of that? The TikTokers and the people who are doing also photos they are getting that opportunity without paying anything. Allow me to, because of in the interest of time and because of most of us who seems to be, the sugars are already low, allow me to read through the speech, which is a bit, which will contain the remarks for Nairobi County. So as we focus on unlocking the potential of community media, it is imperative to underscore that the media landscape in Kenya is among the most vibrant ones in the Horn of Africa. With a solid physical capacity, a variety of print and an extensive broadcast and a robust online presence, thanks to the speed, broadband and mobile phone penetration, Kenya media landscape is considered vibrant and sophisticated. The multifaceted role of journalism and journalists, which is to educate, inform, entertain, and as a society public watchdog, remain an integral part in every democratic space. Therefore, the need for the media to be anchored on people-centered, inclusive, and developmental-oriented information society, where everyone can create, access, and utilize, share information cannot be overemphasized. Today, we gather not to invent the wheel, but to pay homage to the gain made in journalist space, and also to inspire successful generations to onboard on the wagon. We seek to promote media viability across communities in Kenya. Access to information is a fundamental right, however, not to an end in itself. It provides a platform for citizens to enjoy other rights and to effectively partake in public affairs. The county government of Nairobi, under the able leadership of His Excellency Governor Sakaja, underscores the importance of information sharing and recognizing that information sharing must go hand in hand with effective service delivery, as this enables effective planning and implementation of integrated and targeted development goals in the society. It is against this backdrop that Nairobi City County government embarked on a journey to identify and operationalize various ways of information sharing that customers can easily identify with. I don't know whether we are aware that we have a fully fledged public participation, citizen engagement, and customer service directorate. And this directorate is tasked with the mandate to ensure that we engage in citizens at the grassroots level, especially when we are coming up with developmental projects. We also have a vibrant, very robust customer service center at the annex in our HQ in Nairobi. Distinguished guests, they say that success is the sum of small efforts repeated day in and out. I offer not, but I must say that it is time to rethink our craft. The world is evolving at a rate that we must keep abreast with, not forgetting that those behind us are watching us keenly. To the organizers of this conference, that is Kakaberu and all the stakeholders, kudos for bringing us together as a platform, as this platform provides an opportunity for us to strengthen our relationships and amplify our interventions. The Nairobi City County government, under the stewardship of His Excellency Governor Sakaja, we are open to collaborations, and this has been demonstrated by our participation and the support for this year AGJK Community Media. partnerships that are transformative and one that empowers our community and improves the social status of our people. My clarion call to all the media houses is that we must be at the forefront to champion social progress, and therefore we must continue to emphasize on the importance of local news outlets as a catalyst to an informed and a better society, while ensuring that we combat misinformation and strive to promote accurate and reliable information by ensuring we undertake thorough fact-finding and embrace ethical reporting practices. I would like to finish with a quote that is linked to Tax's newspaper editor, and it reads like this: a news story should be like a miniskirt on a pretty woman, long enough to cover the subject, but short enough to be interesting. I wish to repeat. A news story should be like a miniskirt on a pretty woman. A news story, the story that you do every day. Long enough to cover the subject, but short enough to be interesting. As I take my seat, I want to take this opportunity to wish you a sparkling festive season filled with joy and a meaningful story in a bright 2025 year full of impactful reporting. Thank you very much. Like I had said, I don't want to repeat what the other speakers have spoken. There's quite a lot. We've had a very wonderful, meaningful engagement since I came, and I want to believe that was the same case yesterday. And for that reason, I think we can call it a day. So I want to take this opportunity to officially declare the AGJK Community Media Conference officially closed. Thank you.
Wapi makofi ya Madam Vicky? DJ atampatie ngoma ashuke nayo. Yes, very nice, very nice. Thank you so much, CEO. We appreciate your presence. Na ufikishe salamu zetu kwa governor wa gatuzi la Nairobi kutoka hapa Mombasa. Great. So I'm requesting the media team to So this is what I am requesting. And hapa kuna watu mention integrity and all that. This is where our integrity is coming into action. So let us scan the QR code. Please bring it back. Yes, that is a post-evaluation of the conference. As we are stepping out for lunch, let us do our evaluation. Then I will invite Martin to just give us a quick overview of the gala dinner. Then we step out for lunch, then we'll meet in the evening. See you then and bring your energy. Thank you.
Tupigie makofi mazuri jamani. Asante, sitaki kuchukua muda mrefu kwa sababu chapter iko tayari. Tumeambiwa masaa yamekwisha. Nashukuru sana Chief Officer, Public Participation, Citizen Engagement and Customer Care, Nairobi County. Asante sana kwa kuja na kwa mgeni wetu hapa Mombasa kwa ajili ya shughuli hii ambayo tumekuwa nayo siku mbili na tutakuwa na tamatisha jioni ya leo. Pia tushukuru County ya Nairobi, Gavana Sakaja, tuomba ukienda kule mwambie kwamba tumeshukuru sana kama AGJK na
na kila mtu ambaye amekuwa hapa kwa ajili ya support ambayo unaweza kutupatia kuhakikisha kwamba shughuli hii inafanyika vyema. Pia niweze kushukuru baadhi ya watu ambao wamekuwepo, wale wametusaidia sana katika hafla hii, wale partners wote walijitolea kuja kutusapoti kwa njia moja ama nyingine, kwa ajili ya kuhakikisha kwamba wanahabari kutoka maeneo mbalimbali wameweza kukusanyika hapa kwa sababu ya shughuli hii. Kunao SHA, najua tuna maswali mengi ya kuwauliza, tutawauliza kule nje, lakini tunashukuru sana. Asanteni sana kwa msaada ambao umeweza kutupatia kuweza kuboresha kongamano hili. Pia nishukuru Safaricom, wamekuwa msaada sana, japo hakuna mwakilishi aliyekuja, ila wamekuwa wakifuatilia kwenye mtandao. Tunasema asante sana kwa Safaricom. MSF tumetembea nao sana, tunashukuru sana MSF. Kengen tunasema asante sana. Pia Sato wamekuwepo, tunashukuru. Akiba Mashinani, Tika, pia Human Dog Foundation, wale ambao tumewatazama kwenye kiwambo wakituzungumzia kutoka Poland, tunashukuru. Pia kwa ajili ya WhatsApp wamekuwa msaada sana. Gali Effect tunashukuru. Pia Habitat for Humanity na pia Forum Civ kwa kazi nzuri ambayo umeweza kufanya kutusupport kwa hapa. Pia nishukuru wanahabari wote ambao wakati tuliwafikia na mwaliko nikaona ni vyema nyie kuweza kuja hapa kunufaika na kongamano hili la siku mbili. Najua maoni ambayo mnayo kuhusiana na kongamano hili tutafanya pale kwa mtandao, na tutapata hiyo feedback, itatusaidia kuboresha kongamano lijalo mwaka ujao. Pia nichukue fursa hii kushukuru kikosi kizima cha AGJK tukiongozwa na chairman ambaye ni team leader Dennis Beru, fanya kazi nzuri sana, si tumeipenda? Tuwapigie makofi timu ya AGJK. Asanteni sana kwa kuja na wazo hili, mmejitolea sana, najua mmebeba mzigo, lakini leo tunamalizia, inakuwa jambo nzuri sana. Kwa hivyo kwa wale wote ambao wameweza kuja, MC alikuwa ametupa mtindo wa kupiga makofi. Sawa? Tutapiga makofi 5, kuanzia 5 mpaka 1, alafu tutakuwa tumetamatisha, tuende tule. Haya, anda tutayarishe vizuri. Tuanze 1, tupige mpaka 5, tukireduce mpaka 1. Tuende kazi, tuanze. Safi. Tukimalizia nataka nishukuru media team kuanzia jana, nishukuru watu wa sound pia. Kuanzia jana tumefanya kazi nzuri mpaka leo. Tumemaliza conference yetu, nasema sana. Tupige makofi. Shukrani sana. Kwa hivyo conference, kongamano letu tumetamatisha hapa. Nataka tuende Chamcha, kisha baadaye jioni tutakongamana tena, lakini sio hapa. Kuna sehemu imeweza kuandaliwa kwa ajili ya hiyo gala dinner. Tutapatana pale saa 12. Sawa sawa. Tutaanza kuja pale saa 12. Tunataka kufikia saa 4 usiku, saa 4 unusu tukiwa tumemaliza, maana kuna wale ambao wanasafiri kesho asubuhi. Si Mungu awabariki sana. Tunaweza tembea tu kwa taratibu, tuende tupate chakula cha mchana. Bosco. Naelezwa kwa wale wanaotoka kule na kutoka, kuna chai pia. Ukishamaliza kula kuna kikombe cha chai. Kwa hivyo unaweza kupata kikombe cha chai kabla uelekee. Asanteni sana.
Haya, hello guys, lunch tafadhali tuharakishe kwa sababu ya time, tuharakishe twende lunch kwa sababu ya time. The lunch section inaweza fungwa wakati wowote, kwa hivyo kindly tuharakishe twende tule jameni. Asanteni sana.